privilege of now calling upon the next chairpersons for the subsequent session. We have Professor Vijay Ibrahim from Adelaide, the University of Adelaide, Australia, and Dr. Mohammed Ibrahim. Dr. Mohammed Ibrahim is a senior surgical oncologist from Madurai, and he also practices at multiple places in Chennai and Madurai. We have a galaxy of 4 speakers for this evening. We have Professor Rajinder Parshad, we have Professor Sanjiv Haribhakti, Professor Jimmy So, and Professor Ajay Upadhyay. Can I have the honor of inviting the chairpersons to proceed with the session, please?
Hello, can you hear me?
Yes, sir, we are fine. I hope Ibrahim sir is also joining us, but I would say you please proceed with that, sir.
Right. Good morning, good afternoon, good evening to everyone who's joined us. As was already told, we have 4 video sessions, which are how I do it, and we're going to basically concentrate on the technical aspect and the tips and tricks. It's my pleasure to introduce the first presenter, is Professor Rajinder Parshad, who is minimally invasive robotic surgeon, and he's from Department of Surgical Disciplines in All India Institute of Medical Science, professor and head of Surgical Unit 3. I would request Professor Parshad to start his presentation.
I have the presentation of Professor Parshad. Let the video run, then you can ask him the questions.
Can I request all the participants to please type in your questions? We'll find that. We can go on with the presentation, please.
Thank you very much, sir. And first, I would like to thank the organizers for giving me this opportunity. I shall be speaking on laparoscopic myectomy. I have no conflicts of interest. And today I shall be talking a little bit about the steps and the tips and the tricks as to how to perform this operation. We have been involved in doing laparoscopic myectomy for the last 20 years. And whatever I'm going to speak to you today is based on our experience. The patients who are presenting with achalasia cardia are diagnosed using a barium swallow, and time barium is the current standard. Earlier on, we used to do a traditional barium swallow, but now we do a time barium, as you can see here, and this is good for even post-operative evaluation. Manometry is, of course, the gold standard and lets you know whether it is a type 1, type 2, or type 3 achalasia. Now we'll go on to the procedure because of the time limitations. The procedure is done under general anesthesia. Patient is prepared prior to surgery by putting a Riles tube and giving washes depending upon the degree of dilatation. Some people who have very large dilated esophagus may need a longer duration of washes. Otherwise, we can do it the day prior to surgery. Of course, patients are given perioperative antibiotics. The intubation should be a rapid sequence intubation because there is a risk of aspiration. After that, we come to the patient positioning. We position the patient. I'll show you the picture. Create pneumoperitoneum and then place the ports. Again, I'll show you the picture. So this is how the patient is positioned. The surgeon will stand between the legs of the patients, and this is how our ports are placed. The camera port is just above and to the left of the umbilicus, and the remaining ports you can see, these two are the working ports. Here goes the liver retractor, and this is the port for the assistant to help you in the procedure. If you do not have a Nathanson's retractor, then as we earlier did not have, we used to put a small 5 mm port and use a fan retractor or some other instrument to retract the liver. Now, coming to the procedure, once you have created the pneumoperitoneum, once your ports are in position, then we start with the dissection of pars flaccida. Then the hiatal dissection and dissection of the mediastinal component of esophagus. Then we clear the G-junction fat pad. Then we create a myotomy. And then at the end, we do an anti-reflux procedure and confirm that there are no perforations or leak by doing either an intraoperative endoscopy, or in case that is not available, we do a methylene blue dye test to ensure that there are no missed perforations. The hiatus closure is done when indicated, and we'll talk about it. Now, if you ask me, is there one single way of doing all the Hellas myotomy? My answer is no, because it depends a lot on how the patient's anatomy is. And this is what we are talking about. The hiatus and the hiatus is a little patulous. And if you look at picture C, there is a frank hiatus hernia. So these are all of the esophagus. The mobilization remains confined to the anterior part of the. If you have a large hiatus, of course, we have to close it at the end of the surgery. Although we do not close it as snug as one would do for a GRD, but one does have to close this. Otherwise, there is a risk of migration of the esophagus or the G-junction up. What are the structures that we need to preserve? The first structure that you need to preserve, and you will come across the hepatic diet of the vagals. Here you can see it coming here. This is the right crust going up, and this is the pars flaccida. We made a hole below up, and then this is the other structure you would want to preserve is the anterior vagus nerve, which you can see crossing over the anterior surface of the esophagus in a myotomized patient. It usually comes along the left crust, and then that is where you should be looking for it when you are doing your initial. But this is another structure which you need to avoid injuring. Then and unless you see this anatomy, you will not be able to do a proper myotomy, because your myotomy has to extend below the G-junction, and as long as the fat pad is there, you will not be able to discern it properly. Up into the mediastinum. Now, the lower component, I think, is more critical and important. Here you can see the esophagus and the stomach junction. Many a times I have seen, you do a myotomy, you think everything is fine, but this is not fine. You don't have to stop here. You can see here the oblique fibers coming down into the stomach. And unless you take these fibers, you are not going to be doing a proper job, and patient is going to have recurrence or will definitely not be relieved of the symptoms. So this is a general, this is a picture telling you that we come about 2.5 to 3 centimeters below the G-junction, 5 to 6 centimeters above the G-junction. And the key to success, to my mind, is adequate extension across the G-junction. Outside, and then innocence over it, and of course he presented with dysphagia. Angle of his accentuation, which is a very simple procedure where you don't mobilize the esophagus circumferentially, don't divide the short gastrics, and just accentuate the angle of his. And this is what it looks like. It is kind of a half of the door, whereby the left edge of the myotomy and the left crust is sutured to the fundus to accentuate the angle of his. And this is our publication where we compared angle of his with the door, and what our experience is that both give you kind of similar outcomes. With two-pay fundoplication, so as per the randomization, we do our.
This is Professor Tehemton Upadhyay's. I'm sorry for that. Give me a minute.
Giving me this opportunity. This is where you are also going to encounter the submucosal veins which are coursing, and that is what, once they get injured, they operation, because and you can kind of see the veins appearing in the picture, and then you can gently tease off the remaining fibers and open it up. Once you've done that, then we either do a methylene blue dye test. Earlier on, we did not have endoscopy, but now we always prefer to do an intraoperative endoscopy to see the adequacy of the myotomy. And here is an anti-reflux procedure being performed. The one in the main screen is a door fundoplication in progress, and the one in inset is the angle of face accentuation in progress. And here you can see the inset now is showing completed door, and the inset now is showing, just to give you an idea, an angle of face accentuation.
We can have Professor Rajinder for questions, please.
Hello. Thank you, Dr. Prasad, for that beautiful and clear presentation. I'm not able to see any questions. I don't know whether Dr. Ibrahim has any access to questions from any
Let me quickly,
participants. No?
let me quickly check.
Even, sir, good evening. This is Dr. Ibrahim. Even I am not having any access to the questions. Any questions from the participants?
No, at this point, we do not have. There is one question. What was the main complaint of the patient? Which HRM is? I think the question is very clear. What is the indication for HRM prior to myotomy? Dr. Rajinder?
So ideally, all patients should have an HRM prior to myotomy, because that will help you to distinguish between the different types of atlasia. At times, it does happen that one is unable to do an HRM because of, if it's a very dilated esophagus and they are not able to cross, or it may not actually be available in many places in our country. Initially, we didn't have an HRM, but barium gives you a fairly decent idea. But if you have an HRM, you should do it. It also helps you to the post-operative period in case patient has a recurrence of symptoms or something to figure out as to what is happening. And it can differentiate it from some of the other motility disorders where a myotomy may not be of much use.
Do you have any other questions, or do we have time for questions, or we move on to the next?
Time for one more question, Dr. Vijay.
Well, again, I'm not seeing anything. If it is all right, can I ask a question?
Please go ahead.
Right. I mean, I think if you detect a leak intraoperatively, I mean, usually making a hole in the esophagus, it sort of presents itself. You see it. So how do you manage that?
First and foremost is that you must not miss it, and that is why we do either a dye test or intraoperative endoscopy to ensure that you are not missing a leak, because that can be disastrous. And if you do see it, then we close it using a 3-0 vicule and put a door over the as a anti-reflux procedure and cover it with a door patch. And then you would want to kind of do a gastrograph after 48 hours just to ensure that everything is fine.
Yeah, thank you. Can I request my co-chair to introduce the next speaker, and shall we move on to the next presentation?
Thank you, Professor Rajinder.
Thank you.
Thank you, sir. Thank you, Dr. Rajinder. Thank you, sir.
Good evening, Professor Jimmy.
Yes.
Give me a few minutes for your presentation.
Huh? Are we ready?
No, we have. Are you ready to go, Professor Jimmy?
Yes, I'm ready.
Yeah, please go ahead. I think I will request the chairpersons to escalate Dr. Jimmy so to finish his presentation. Is that fine, chairpersons?
Hold on.
I think Dr. Yes, sir. Dr. Vijay also will be accepting it.
Yeah.
Yes, sir. We'll go with the MIS.
Yeah.
Let me share that my screen.
Please, sir.
Yeah, can you see my screen, please?
Yes, sir.
Yes. Yes, sir.
Yes. Good evening, everyone. I'm very happy to be here Yes, thank you for Dr. Kanaka for the kind invitation for the INDO-UK SURGICON conference. So my task today is to share with you my experience on the laparoscopic D2 gastrectomy. Just a brief historical perspective on the world first laparoscopic gastrectomy actually was performed by Professor Peter Goh, my teachers in Singapore in 1992. And this is the original report published in the journal Surgical Laparoscopy and Endoscopy. And you can see that this procedure at the time described is the technique for laparoscopic period 2 gastrectomy was for peptic ulcer disease. 2 years later, Professor Seigo Kitano, as shown here, was performed the first laparoscopic gastrectomy for cancer. And this is the original picture for the first case of laparoscopic gastrectomy for early gastric cancer performed by Professor Kitano in Oita University. How about scientific evidence? This is the current treatment guideline based on the Japanese Gastric Cancer Associations. Currently, the gastric cancer guideline recommended that laparoscopic gastrectomy is indicated for early stage 1 gastric cancer. There's many scientific evidence, especially well-known the Korean study, the CAST-01 study, published JAMA Oncology in 2019, which later I will allude to all. However, for advanced cancer, laparoscopic surgery is, although it's feasible, but it's not yet recommended routinely. This is the paper talk about for laparoscopic distal gastrectomy for stage 1 gastric cancer. This is a Korean CAST-01 randomized study. This is a Korean CAST-01 randomized study. So this study has published a few reports. In the latest report, looking at the final endpoint, the primary endpoint of the study, they were in terms of the both overall survival or cancer-specific survival. Laparoscopic gastrectomy have an equivalent oncological outcomes compared to open gastrectomy. And the same group previously have shown that the perioperative complications were significantly lower in a laparoscopic gastrectomy than open gastrectomy. Hence now the treatment guideline recommended for stage 1 gastric cancer, laparoscopic gastrectomy is one of the standard options. For advanced, locally advanced gastric cancer, last 2 years there's some evidence has returned. And this is the study from China called CAST-01 study. It's looking at laparoscopic gastrectomy for locally advanced gastric cancer. And this is a randomized control trial. So it was published last year in terms of the primary endpoint on the survival. So this is a randomized trial recruiting patients from T2 to T4A gastric cancer with low bulky lymph nodes. And as you can see that from this survival curve, there's laparoscopic and open surgery, there's no significant difference in terms of the survival. But in terms of looking at subgroup analysis, looking and break down the patients into different stages, you can see that there's overall there's no difference between in each stage, but they can see that the solid lines are the patient with laparoscopic surgery, and broken lines are the open surgery. You can see there's a trend towards better survival for the open group. And you can see that from the stage 4A cancers, there's some slight trends towards higher risk of recurrence for the laparoscopic group, indicating there's some reservation for more locally advanced gastric cancer for laparoscopic using laparoscopic techniques. But recently, the Korean group, the CLASS group, published the second study looking at laparoscopic distal gastrectomy for, this time around is for locally advanced gastric cancer. And this study was just published last month in the Journal of Clinical Oncology. And they reported that in terms of the early complication, laparoscopic surgery has less complications compared to open surgery. And but in terms of local complication, these are equivalents. No difference between the two groups. But on the survival outcome, in this Korean study, have shown that laparoscopic surgery and open surgery have equivalence in terms of oncological outcomes, indicating that laparoscopic surgery is safe and feasible even for locally advanced gastric cancer. This is our operative technique for laparoscopic distal gastrectomy. We usually perform that in a supine position with five-pot techniques. We use stepwise techniques for distal gastrectomy. As you know that radical gastrectomy is a complex procedure. We break down easier to break down into various steps, including the first step is to remove the greater omentum of the station 4 lymph flux. Then to remove the right side of the infrapyloric dissection to remove the station 6 lymph node. Then go to the lesser curvature to do a supraduodenal dissection in the aim to remove the station 5 lymph node, and followed by a duodenal transections. And then the next part will be the D2 gastrectomy, which is the suprapancreatic dissection along the pancreatic border to remove the station 8A, 9, 11P, and the station 7 lymph nodes. And then we'll follow by the right cardio dissections and the resecting of stomach and the anastomosis. So this is our stepwise approach of laparoscopic gastrectomy, as mentioned, including division of the greater omentum. The second is the infrapyloric dissection, followed by a suprapyloric dissection, celiac axis dissection, and right cardio dissection and the gastric resection. And finally, the reconstruction. Nowadays, we more commonly perform an intracorporeal anastomosis. Just a very brief video about our technique of laparoscopic D2 gastrectomy for locally advanced cancer with a gastric outlet obstructions. So first of all, we divided the greater omentum from the border at the transverse colon. And towards the left side, seeing the root of the left gastroepipodic vessels. So this is the base of the left gastroepipodic vessels near the inferior pole of the spleen. And then we clip the vessels and then we divide it with an energy device. After that, we turn to the subpyloric, infrapyloric areas to dissect the right gastroepipodic vein and the right gastroepipodic arteries. So you can see that here is the head of the pancreas at the border of the head of the pancreas. And we isolated the vessels and then we divided at the root of these vessels using the clips and then followed by the energy device. Then after that, we go to the suprapyloric area. This is the right side, just above the superior border of the duodenum. And then we get creating a vascular window. Then along the right hepatic arteries, we get to the right gastric artery. And this is the border of the right gastric arteries. Then we clip and divide the right gastric artery to remove the station 5 lymph nodes. Follow that, then we transect the duodenum with a stapler. Then we'll do what we call the suprapancreatic dissection, which is the juice of the D2 lymph node dissection. So we can see that this is the body of the pancreas. We dissect on the superior border. This is the right common hepatic arteries. We are dissecting the lymph node station 8 lymph nodes and follow it distally towards the hepatic artery proper. As here is the station 12A lymph node along at the groove between the hepatic artery proper and the portal vein. Now this is the portal vein is around this area. As is case that this is a locally advanced cancer, therefore adequate lymph node dissection is indicated. This is the portal vein. Once that, then we divided the lymphatics from the hepatic artery. Follow that, then turn to the left side and along the distal part of the pancreas, follow the superior border of the pancreatic tails along the splenic arteries and the splenic vein. And in these patients, the vein is more superficial compared to the arteries. which is a little bit of anatomical anomaly. And then we're dissecting the 11P lymph nodes, which is just about the splenic artery and the splenic vein. This type of energy device is nice because it is curve shape, which is helping to our dissections. Now we turn to the left gastric vein and the left gastric arteries. This is the left gastric vein. We clip and divide the left gastric veins. Therefore, we are now on the root of the left gastric arteries. And this is the lymphatics along the arteries. We skeletonize it, and then we'll clip and double clip and then divide the left gastric arteries. Finally, we dissect the right cardio lymph nodes along the cardia of the right side. In this case, it's a distal gastrectomy. Therefore, we need to skeletonize the upper part of the left cardia. And after that, we divided the stomach and then perform the anastomosis. We perform a wool and white gastrojejunostomy. This is the proximal jejunum. They make an opening in the jejunum. And then we perform the gastrojejunostomy using the mechanical stapler. They will insert the cartilage into the small intestine site, and then the metallic part will enter into the gastric gastrostomy, and that's the way we created the gastrojejunostomy. And then with the common stable wound, we close it with the relock stitch. Some people will perform closure with this part of the closure using a stapler, but we prefer using a sutures just to avoid stenosis. This is the closure of the common stable wound, and after that we close the mesenteric defects. Then this is the jejunostomy. Same techniques using a stapler and closure of the common stable wound with sutures. And we also put a couch stage at the end, at the two ends, to relieve the tensions. And divided at the end, we divided the wool limb to create the wool and white, to complete the wool and white gastrojejunostomy. So in summary, ladies and gentlemen, laparoscopic surgery for advanced gastric cancer is more technically demanding because we are dealing with a bulky tumor, locally advanced tumor. We need to avoid a tumor spillage and also have to provide adequate surgical margins. The lymph nodes are frequently enlarged, and we need to adequate lymph node dissection is essential for advanced gastric cancer, and that we have to be aware of vascular invasions and the inadequate resection of the lymph node. And certainly, this procedure is associated with higher risk of operative complications. Hence, laparoscopic surgery for more locally advanced gastric cancer are still evolving. Adequate surgical skills are essential for this procedure. With this, thank you so much for your attention and take care, everyone, during this pandemic. We're happy to take any question at the end of this talk. Thank you.
Professor, so I think we have just exceeded the time. Maybe I can permit one question from the floor. Ibrahim, do you like to ask one question to Professor So?
Yes, sir. Yes, sir. It was a wonderful presentation.
Thank you. Yeah, please go ahead.
Sir, it's a wonderful presentation by Professor So. So there is one question mainly for the youngsters. So what will be the contraindication? So what will be the contraindication for a laparoscopic gastrectomy, which is not a contraindication for an open gastrectomy. So is there anything additional contraindication for a lap gastrectomy?
I think that if there's that if there's encounter any problem during the procedures, that is, for example, the invading to the surroundings organs or important vascular structures, I have no hesitation to convert it to an open, because I think safety and adequate resection is the key for the patients. I think we can perform minimally invasively. Of course, it's a bonus to the patients. So I hope that I think that if there's any doubts during the surgical resections will jeopardize either the surgical clearance or safety for the patient, then I won't proceed.
Thank you, sir. Thank you for your wonderful explanation, and it was a very nice presentation. We welcome you to India next year post-pandemic for a live surgery. Thank you so much.
Thank you so much. Thank you.
Thank you, Professor Jimmy. Now, I would like to call upon Dr. Sanjiv Haribhakti. Sanjiv Haribhakti has joined us. Chairperson, please introduce Sanjiv Haribhakti. I will play the video for Dr. Sanjiv.
So welcome, sir. Welcome, Dr. Sanjiv Haribhakti. So, sir is going to present a topic on cystogastrostomy and gastrostomy and cystojejunostomy. So, sir is a surgical gastroenterologist with the qualification of MCH, and he's a chairman in the Department of Surgical Gastroenterology from Kaizen Hospital. So, I think it is in Ahmedabad, Gujarat. Sir, welcome, sir. Please go ahead with the presentation.
Thank you, Dr. Ibrahim. Okay, so I'm talking about pseudocyst. As you all know, it's an encapsulated fluid collection, and usually it takes about 4 weeks to get matured according to the recent revised Atlanta classification. It should by definition contain minimal or no necrosis, and this is a classical CT scan appearance. It's a well-formed cyst wall which is enhancing. It has a homogeneous fluid density and no non-liquid component. So depending on the location, the indications would depend on mainly the presence of symptoms. Symptomatic cyst definitely would need treatment. Size is not in itself a criteria, but a large cyst more than 6 to 8 centimeters will definitely need some kind of intervention. Complications in form of infection or hemorrhage will also need treatment. And these are the methods for internal drainage. Mostly either endoscopic or surgical methods are used. Endoscopic may be US guided most of the times, either a cystogastrostomy, jejunostomy, or a duodenostomy, depending on the location. And the factors that affect the procedure selection are the general condition of the patient, size, number, and location of the cyst, presence of communication, infection, suspicion of malignancy, and the availability of the expertise of endoscopic as well as minimal access surgery. This is a classical cystogastrostomy, which is a posterior cystogastrostomy, and the commonest way to do this is a transgastric, opening the anterior wall. But for this, the location must be conducive so that you can get a good drainage, and which may not be. And these are the two ways of doing the cystogastrostomy. One is surgeon standing in between the legs of the patient, and the other way, and here these are the port placements for the surgeon, typically very similar to a fundoplication, but one has to get the ports above. And this is the second way of doing the cystogastrostomy, where the surgeon is standing on the right side of the patient, and this gives a good exposure for suturing, especially when you're doing a cystogastrostomy with a lower, it's on the antrum, not on the body. So here the angulation for suturing is much better. So I'm just showing you one cystogastrostomy. This is a laparoscopic cystogastrostomy, and this you can see here that the anterior wall of the stomach is open on the antrum. This was a large cyst, so it required aspiration with a Veress needle. After confirmation, this can be done percutaneously, and then the trocar was inserted into the cyst and aspiration was done so that we get a good exposure of surgery. And with a large anterior opening, the cyst wall, posterior wall is also removed, and excision of the cyst wall, posterior wall is done so that you can have a good wide, at least 5 centimeter opening of the posterior wall. Whatever necrotic material is present, generally only minimal necrosis is there, is removed, and then a thorough lavage and debridement is done, and then a cystogastrostomy is done by a continuous suturing of either Vicryl or PDS is done. Generally an absorbable suture is used, and this should be a locking sutures, because common to have bleeding from this cyst wall, from the stomach wall. It's one of the not so uncommon complications of cystogastrostomy. So this, as you come to the end of the session, at the end of the suture line, one should go across the suture line and then tie the knot so that there is a secure, anastomosis. So after this is done, the anterior wall of the stomach is closed. That is the last bite being taken. The anterior wall of the stomach is then closed and a rice tube is placed into the stomach. And this is done generally with a continuous closure. A single layer closure would also be sufficient. You could also, one can also do a 2-layer closure, whatever one is comfortable with. So with this, this is the end of the cystogastrostomy. The other method is the cystojejunostomy. Cystojejunostomy typically needs a Roux-en-Y loop of the jejunum, and this could be through the gastrocolic or the mesocolic route, depending on the location of the cyst. This, I'm showing you a gastrocolic cyst placement. The ports are slightly lower than the cystogastrostomy. As we go in, we'll first do a diagnostic laparoscopy, and then the lesser sec entry is done. This could be transmesocolic or gastrocolic, as I said, depending on where is the location of the cyst. Once you identify the cyst wall, we need to confirm the cyst wall by aspiration of the serocyst. And once this is done, then the cyst wall is entered. Make sure that there is not much spillage. Suction must be very close there. Biopsy of the cyst wall should be done as a routine so that we don't miss any true cyst or cystic lesions or cystic malignancies. Then a roux limb is prepared from the second loop of the jejunum, and here you can see that the stapler is passed and the jejunum is divided. We prefer to do first a jejunostomy so that the infracolic amount of work is done, and then we shift to the cystojejunostomy. So here you can see that the 2 stage sutures are taken and a stapled jejunostomy is created. The jejunum is being opened. Sorry, there are some glitches in the, but you could see here that the stapled jejunostomy is being performed. And the jejunotomy is closed by continuous vicryl suture. Then the cystojejunostomy is generally done as a hand-sewn anastomosis. It's a single layer. We prefer to do an interrupted. Here you can see that the wall is quite mature, quite thick. Sometimes the wall can be quite friable also. So after the posterior layer is done, we open the jejunum and then take the anterior layer. The anterior layer is also an interrupted suture, and generally we use a 45-centimeter roux limb. The third technique that I want to show you is a minimally invasive technique. It's a small incision of about 4 to 5 centimeters in the epigastrium. What we do is we inflate the stomach with a Ryle's tube, and we sometimes use, here you can see that through this small incision, the stomach is held up, the posterior wall is entered, and a stapled cystogastrostomy is created. And then subsequently, we do a lavage. If there is any necrosis, that is also removed through this small incision. And then we place in a Sil's port into the cavity. And from here, we will get in and see the completeness of the necrosectomy. You can see here now that we are in the cavity. Whatever little amount of necrosum is present can be debrided with this and can be removed with this minimally invasive method. So it's basically a small incision cystogastrostomy, and we use the Sil's port and the endoscopic methods to assess the completeness. One has to be very gentle when one does a minimally invasive necrosectomy. Finally, the Sil's port is removed. The anterior opening of the stomach is then closed. We can also do this under laparoscopic guidance to decide where we want to put the skin incision. It would be a 5mm telescope, under which guidance we can inflate the stomach and decide. So with this, to conclude, laparoscopic cyst-centric anastomosis is safe and effective. Indications and selection should be done individualized according to the symptoms of the patient, the location of the cyst, and the size and the available expertise based on the symptoms and the imaging modalities. Thank you very much.
Thank you, sir. Thank you, Dr. Haribhakti. It was a wonderful presentation. So is there any questions from the floor, sir? Can I go
No,
ahead, sir?
I can't see any, so.
So one question, sir. So this is cystogastrostomy is one of a very good surgery for residents. Actually, everything is set up. You just go put an incision and put the suture and come back. Sometimes this cystogastrostomy can be a havoc if there is a splenic artery aneurysm due to pancreatitis. So, do you routinely advise entering into the cyst, that is into the pseudocyst, with the camera and examine the wall inside also, or just come out with the anastomosis and come out?
Yeah. So basically, a preoperative CT scan will show if there are any pseudoaneurysms of great vessels. So that is a must. I think that's a good point that you have brought out. During surgery, we certainly like to see that most of the necrosum has been removed. With this large incision, if there is some amount of necrosum which is left behind, it can easily be, it will come out. That's not an issue. But most of the times, you'll try to see whatever is separated, separatable, should be removed at the time of surgery. So we would always go into the cyst and look at the pancreatic bed and see, and then nowadays if we give enough time, say after 5 or 6 weeks, then generally most of the necrosum is quite demarcated and can be easily debrided. So any major vascular injuries can be avoided.
Thank you, Dr. Sanjiv. Thank you, Chairpersons. Thank you for joining us today and sharing your expertise. Now, can we invite Professor Ajay, Chairpersons, please?
Thank you, Dr. Well, thank you.
Good morning, Dr. Ajay.
It's very early in the morning.
Yes. So,
Yes,
it's my pleasure to introduce Dr. Ajay Upadhyay. He'll be talking about Foregut GIST. He is a program director for the minimally invasive surgery, robotic and bariatric surgery, medical director, metabolic bariatric surgery, chair of the robotic surgery committee, the Altabate Summit Medical Center, Oakland, California. Thank you very much, and please can go on with your presentation.
Okay, first of all, I'd like to thank the leadership and the organizing committee, Dr. Raymond Goyal, Dr. Lal, and Dr. Carnegie, and all of my other co-speakers there for inviting me and giving me this opportunity to share my experience with Foregut GIST. Let's see, shall I play the video here, share it, or the one you have? Oh yeah, go ahead. I think you can start. I would like to thank the organizing committee for asking me to present my experience with Foregut GIST, how I do it. I have no conflict of interest. My assignment today is to talk about Foregut GIST, and these constitute basically gastric GIST, esophageal and G-junction tumors, and rarely duodenal tumors. So majority of these can be approached by a minimal access surgery, the laparoscopic and robotic. Endoscopic resection is suitable for many of these, hybrid MIS and endoscopic resection, and finally open surgery for larger tumors. So this is a CT of one of our radiologists. She had some abdominal discomfort and some heartburn, and a CT scan showed basically a multilobulated anterior gastric fundus lesion. So gastrocolic omentum is divided with a energy device. There's also a hernia, tumor away from the G-junction, multiple linear stapler firing, and you achieve a good resection margin. This is a super obese patient, BMI 103, came with a GI bleed. Endoscopy shows a bleeding ulcer. So we divide the gastrocolic omentum as one will do for a sleeve gastrectomy. Large tumor, intraluminal and exophatic. Again, a robotic approach is ergonomically better for a high BMI. And again, linear stapler, a standard sleeve gastrectomy technique. I use a transilluminated bougie. Now, tumors near the G junction, lesser curved gysts and duodenal gyst pose a totally different issue. So this is a incidentally discovered, very well subscribed, hypodense, well-marginated mass, about 2.7 centimeter near the G junction. An EGD and an endoscopic ultrasound was performed. A 3 centimeter mass just beyond the G junction appeared to arise from the fourth layer. So a robotic technique was used, transgastric approach. Since the lesion was arising from the fourth layer, the mucosa was incised. The tumor was dissected. And an endoscope is always present. And as you can see, it shelled out nicely. The suture closure of the mucosa was performed. A duodenal gyst. Cauterization of the duodenum. The tumor is more visible now. Small bowel is divided near the ligament of Treitz. Mobilization of the DJ flexure. This is very similar to when we are doing a robotic pancreatic duodenectomy. These are small blood vessels feeding the tumor. These are clipped and divided. The duodenum proximal to the tumor is then incised, so the second part. There is a good margin. The jejunum is brought up. A Penrose drain is sutured to the jejunum is helpful. The sutures are placed. The Penrose drain is removed. A linear stapler is used to create an side-to-side anastomosis between the second part of the duodenum and the jejunum. The enterotomy from the stapling is suture closed. So this is a lesion on the posterior aspect of the stomach, more towards the lesser curve. The stomach has been folded over and a suture placed on the tumor allows you to pull it laterally and fire a stapler.
Thank you, Dr. Upadhyay, for that wonderful presentation. And they were really challenging cases, but I think you've done them beautifully. I'm not seeing any questions, but I think the time is up. Is that correct?
Can request
Okay.
you to ask 1 or 2 questions, please, and close.
Is any of the panelists would like to ask any questions?
Excellent videos, Dr. Upadhyay. Great to see you. A very early morning. Sorry to wake you up early in the morning.
Oh, that's okay. Pretty good.
Thank you so much. And I think very educative. You've shown all the range of locations of GIST and how to tackle them very, very ingeniously, I would say, because these are more practical tips. They are not there in the books. So great work done both laparoscopically and robotically. Thank you.
Very good. Well, thank you.
Dr. Upadhyay, can I just ask a question if you don't mind?
Yes, go ahead.
Now, I did notice that you're taking sutures on the tumor. Are you concerned you may be spilling some?
So these were already biopsied. They were very, low grade, and the actually stitches right close to it, and small tumor in the back. And actually, the part of the video looks like got missed where you can, normally if you try to fire a stapler is hard, but putting that stitch around it, you could pull it to the side, then fire the stapler. There was other videos where we have gone through the stomach anterior part, then go in the back, and you can lift it up and fire a stapler or cut it and then hand sew it. So we have some of those, but because of the lack of time, I couldn't show, and I think the last video got stopped for some reason, wasn't playing next to it, but that's one of the techniques that's helpful.
Yeah. Thank you very much. I think on behalf of the organizers and my co-chair, I would like to thank all the presenters. I think it was a really wonderful session, and thank you very much.
Thank you. Although I've been up all night, I've been watching some of other sessions. It's really a great conference, even starting with before the ceremony, I was watching some of the videos. Really, really great presentations, and line up. I'll stay awake for another hour or so, then go to sleep.
Thank you, sir.
Thank you very much. Thank you.
Thank you. Thank you.
Thank you very much.
Professor Upadhyay.